Welcome back everyone. Today is the second session of the journey we had started 4 days back, a journey to learn about childhood tuberculosis. In our last class we had discussed about the introduction and the basic pathogenesis of childhood tuberculosis, and today we are going to learn about the diagnosis of pulmonary tuberculosis in children. So the outline of our discussion today will be, we will learn about some definitions, some very important definitions in pediatric pulmonary tuberculosis. We'll discuss the pediatric pulmonary tuberculosis diagnostic algorithm. We'll see some chest imaging in tuberculosis, and we'll learn about the microbiological and other tests that are done in tuberculosis. So now coming to the definitions. What is the case of presumptive pulmonary tuberculosis? What is a case of presumptive extrapulmonary tuberculosis? And what is a case of presumptive drug-resistant tuberculosis? These are the three important definitions we need to learn in case of pulmonary tuberculosis in children. So why need to learn these definitions? Because any patient that fulfills the criteria of these definitions has to be evaluated in line of diagnosing tuberculosis. So what is a case of presumptive pulmonary tuberculosis? Any pediatric patient who has persistent, unexplained fever and or cough for more than equal to 2 weeks. Any pediatric patient who has history of unexplained weight loss, that is more than 5% or no weight gain in the last 3 months. Any pediatric patient who has history of contact with infectious TB case within the past 2 years. Any pediatric patient who fulfills any of these criteria has to be considered a case of presumptive pediatric pulmonary tuberculosis. Coming again, any pediatric patient who has persistent unexplained fever and or cough for more than equal to 2 weeks, any history of significant unexplained weight loss. Significant weight loss means more than equal to 5% in the last 3 months or no weight gain in the last 3 months, and any pediatric patient with any history of contact with infectious TB case within the past 2 years. This is a case of presumptive pulmonary tuberculosis. That means any patient fulfilling these criteria has to be evaluated, has to be entered into the diagnostic algorithm of presumptive pulmonary tuberculosis. Likewise, who is a case of presumptive extrapulmonary TB? Any patient along with this who has presence of organ specific symptoms like lymph node swelling, arthritis or CNS symptoms like neck stiffness or disorientation, any constitutional symptoms like significant weight loss, persistent fever for more than equal to 2 weeks, night sweats, the cause of which has not been yet determined. Any unexplained presence of these symptoms has to be considered a case of presumptive extrapulmonary tuberculosis. And last but not least, very important, what is a case of presumptive drug resistant tuberculosis? Any patient who has failed treatment with first line drugs. Suppose we have diagnosed a case of tuberculosis previously and started him on first line drugs, HRJD, and the patient has failed the treatment. That means at the end of the treatment, the patient is still considered positive for tuberculosis. That means he has failed treatment with the first line drugs. That will be considered a case of presumptive drug resistant tuberculosis. Any pediatric TB non-responders, that means any first line drugs or second line drugs, anything, if a pediatric TB has not responded to the treatment, he has to be considered a presumptive drug resistant case. Any TB patient who are contacts of a drug resistant TB case, that means suppose if you diagnose a case of newly diagnosed tuberculosis who has a positive contact history with another case of tuberculosis who is a drug resistant TB, that means this patient, this newly diagnosed patient is also a case of presumptive drug resistant tuberculosis. Any TB patient who is found positive on any follow-up sputum smear examination during the treatment with first line drugs. If we start a patient on first line drugs, after a certain period of time we have to examine the sputum smear. If on examination of that sputum smear, if we find the patient is still positive for acid-fast bacilli, we have to consider that the patient is a case of presumptive drug-resistant tuberculosis. Any previously treated TB case, that means any person who has taken anti-tubercular therapy for more than equal to 1 month in his life, has to be considered a previously treated TB case. And any previously treated TB case that has come to you again is considered a presumptive drug resistant tuberculosis. And very important, any TB case who has HIV co-infection is always a case of presumptive drug resistant tuberculosis. So any patient who fulfills criteria of any of these things is a case of presumptive pediatric TB. So that patient has to be taken up for the evaluation or the diagnostic algorithm of presumptive pediatric tuberculosis. Now two more important definitions. Who is a contact and who is a close contact? Any individual exposed to a person with active TB disease, that is a contact. But who is a close contact? Any person who is not in the household but shares an enclosed space. What is an enclosed space? A social gathering, a workplace or any facility for extended periods during the day with the index TB patient during the 3 months before commencement of current TB episode. That means suppose a patient has come to you with symptoms suggestive of tuberculosis, and in the last 3 months he has been in contact with another person who is a known or diagnosed case of tuberculosis, with whom this person has shared increased amounts of time or extended periods of time in an enclosed space. That person will be considered a close contact. Important to know is that both a contact and a close contact both will be considered a positive contact history for tuberculosis. So now coming to the diagnosis of pulmonary tuberculosis, this thing is very important. What we need to know is that the diagnosis of pulmonary tuberculosis mainly relies on two investigations. One is the chest x-ray, another is the NAT. NAT stands for nucleic acid amplification test. If you want to take any message from today's class, this is the most important thing, that if we want to diagnose pulmonary tuberculosis in children, the two investigations that we rely most upon is chest x-ray and nucleic acid amplification test. Without the help of these investigations, we cannot diagnose a case of pediatric pulmonary tuberculosis. The major burden of diagnosing pulmonary tuberculosis is resting upon these two investigations. So what have we learned till now? Any patient who has persistent unexplained fever or cough for more than 2 weeks, or significant weight loss in the last 3 months, or no weight gain in the last 3 months, or any child with severe acute malnutrition who is under nutritional rehabilitation but in spite of that is not having appropriate weight gain, or any child who is having contact history positive with any case of pulmonary tuberculosis within the past 2 years is a case of presumptive pediatric tuberculosis. So presumptive pediatric tuberculosis means what? We have to enter this child right now into the pediatric tuberculosis diagnostic algorithm. So what is the next step that we do? We just now learned that there are two main investigations that we rely upon for diagnosing pediatric tuberculosis. One is chest x-ray, one is nucleic acid amplification test or NAT. So here we do chest x-ray. Previously this guideline was slightly different. Previously we needed to do two investigations initially. One is chest x-ray, one is tuberculin skin test, but now it has been changed. Now with time progressing, the tuberculin skin test is being given less and less importance. Why? We'll learn in a bit. So right now we'll need to do a chest x-ray. If we do chest x-ray in this child, one of the three things may happen. Either the chest x-ray may be completely normal, or the chest x-ray can have some non-specific shadows, or the chest x-ray can have some findings which are very specific for tuberculosis. That means these findings are seen only and only in tuberculosis only. So we'll discuss one by one these scenarios. If the chest x-ray is normal, think about this scenario. The child is a case of presumptive pediatric tuberculosis. That means we are suspecting that the Mycobacterium tuberculosis is present in this patient, but the chest x-ray is normal. So what can be the possibility? The possibility is that the Mycobacterium tuberculosis is lying elsewhere, not in the chest. So what is that called? That is called extrapulmonary tuberculosis. So we have to think about what? We have to check for extrapulmonary tuberculosis. That means we have to see the other sides, examine the other sides, send the appropriate investigations. We have to do the detailed investigations as needed, and we have to think about alternate causes of the symptoms also. This patient may require contrast enhanced CT scan also, and if whatever the investigations the patient requires, those are not available in your setup, we have to think about referring the patient to a higher center or another center for further investigations. Next, if the patient is having some findings in the chest x-ray that are seen only and only in tuberculosis, that means findings highly suggestive of tuberculosis, that means this patient is matching our expectations of finding a tuberculosis. So we have to think about what? We have to do what next? We have to examine, and we have to see, or we have to think, how can we confirm a diagnosis of pulmonary tuberculosis in this patient? That means we had suspected pediatric TB. Now the chest x-ray is showing positive findings. That means the TB is present in the chest only. So we have to confirm a finding of, or confirm a diagnosis of pulmonary tuberculosis. So we have to send a sample originating in the pulmonary system or respiratory system for diagnosis of tuberculosis. So what are the samples that can be sent? If the patient can expectorate some sputum, that will be very good. So we have to send that for nucleic acid amplification test. Or if suppose the patient cannot expectorate the sputum, we can help him. We can get some induced sputum by nebulization and we can send that for nucleic acid amplification. But if we cannot get expectorated sputum or induced sputum also, we have to send gastric aspirate, assuming that some amount of sputum is repeatedly getting aspirated inside the GIT, and we have to send that, and we have to hope for a presence of a Mycobacterium tuberculosis in that sample. So that can be called as a surrogate sample. So we have to send either expectorated sputum or induced sputum or a gastric aspirate for nucleic acid amplification test. So if the nucleic acid amplification test comes positive, what does the nucleic acid amplification test do? It amplifies the nucleic acid present in the Mycobacterium tuberculosis. So if the nucleic acid amplification test or NAT is positive, that means microbiological presence of tubercle bacilli in that patient has been confirmed. So this can be called as a case of microbiologically confirmed TB. This is the most confirmatory diagnosis you can get in tuberculosis. But suppose if the NAT is getting negative, this patient was a presumptive case of pediatric TB. You had got highly suggestive findings of chest X-ray of tuberculosis here in the chest X-ray, but the NAT is coming positive. So what might be the possibility? First possibility, you have not sent an appropriate sample. Second possibility, you have not sent an adequate sample. Third possibility, that this might be a false negative. So what we need to do in all those scenarios, you have to think about sending the appropriate sample again, adequate amount. You have to think about, is there any other focus of tuberculosis anywhere else in the body? Maybe if I get a sample from there, I'll get a higher yield or a higher chance of getting tuberculosis positive. And suppose if I don't think that also, I'll just repeat this test, repeat this sample and do NAT again, because this might be a case of false negative. So what do we do in those cases? You have to look for other sites like lymph node. You have to repeat the NAT from better quality specimen or alternative specimen like bronchoalveolar lavage, because it has a slightly higher sensitivity. And you have to get a review from higher center if you are confused about the diagnosis. And you have to repeat the NAT again. Any time in the diagnostic algorithm is done, if the NAT comes positive, that means the microbiological presence of tubercle bacilli in the patient has just been confirmed, and you can label the patient a case of microbiologically confirmed tuberculosis. But suppose the NAT comes negative again, so what might be the possibility? You had thought of this patient as a presumptive pediatric tuberculosis, chest X-ray was highly suggestive, you have sent an appropriate sample, but the NAT is coming negative. That means only two possibilities are left here. One possibility, the diagnosis is not tuberculosis. That means you are considering, you are missing something. There is some alternate diagnosis possible here, but you are missing something. That means first step is to rule out alternate causes or alternate diagnosis that can explain all these symptoms. Second thing is, the tuberculosis is actually present in this patient, but due to some reason you are not getting the NAT positive. This might be very possibacillary, as we explained, as we discussed in the last session. The TB might be very, TB load may be very less. So in that case, we may not be able to get a microbiological confirmation of tuberculosis. So in that case, we may make a diagnosis of clinically confirmed or clinically diagnosed tuberculosis. So what might be the possibility in this scenario? No other likely alternate diagnosis, we have to think about that first. If no alternate diagnosis is thought of or can be confirmed, we have to treat this as a case of clinically diagnosed probable tuberculosis. And the middle scenario, if the chest X-ray has non-specific shadows, that means some shadows are there, chest X-ray is completely not normal, but those shadows are not very specific for tuberculosis. That means that can be present in, or that can be caused by some other diagnosis also, other causes also. So what we need to do in this case, we have to think and treat those causes. Suppose this is a case of bacterial pneumonia, we have to treat the bacterial pneumonia and see if the patient is responding or not. If the patient is not responding, then we have to think, if the patient is responding, our alternate diagnosis is proved. So what we need to do in this scenario, we have to give a course of appropriate antibiotics. What does the appropriate antibiotics means? That means monotherapy with an antibiotic which doesn't have antitubercular effect. Why not an antitubercular effect? Because if suppose we give an antibiotic of antibiotic which has antitubercular effect, that will clinically suppress the tubercle bacilli, that will cause transient improvement in symptoms, transient improvement in findings, and the patient will be well and happy. He will not take any treatment, he will go home. Monotherapy is not recommended in tuberculosis. We'll discuss why later on. But now, later when the patient will present as a case of drug resistant tuberculosis, because monotherapy will give rise to drug resistance. So we have to choose an antibiotic which doesn't have any antitubercular effect. Most likely amoxicillin or co-amoxiclav is the recommended antibiotic. If after giving antibiotic the patient still has persistent shadow or persistent symptoms, then we have to think about all these things again. Okay. But the story doesn't end there. Why? Because whenever we do nucleic acid amplification test, it gives us two results, not one. What are the two results? If the NAT is negative, it will tell that Mycobacterium tuberculosis not detected. That's over. But suppose if the NAT comes positive, it will tell that Mycobacterium tuberculosis detected, plus it will give us another finding. What is that? The NAT is a very good test because it gives us some additional information about rifampicin resistance. Important to know, it doesn't give any information about rifampicin sensitiveness. It gives us information about rifampicin resistance. That means this patient, the Mycobacterium tuberculosis present in this patient, whether that tubercle bacilli is resistant to rifampicin or not. If suppose rifampicin resistance is detected, presence of rifampicin resistance means we have to think this is a case of drug resistant tuberculosis and we have to enter the patient into the drug resistant tuberculosis pathway. Suppose rifampicin resistance is not detected, we have to think that this is drug sensitive tuberculosis and we have to start first line drugs. And most important thing, HIV testing is to be offered to all the children diagnosed with tuberculosis, irrespective of any history, irrespective of any finding, everything. Every patient diagnosed to have tuberculosis has to be mandatorily offered and, if agreeing, tested for HIV infection. That is the important message. So this is the diagnostic algorithm for presumptive pediatric tuberculosis. What did we do? We did a chest x-ray initially, and depending upon the chest x-ray findings, we did the second line investigations. Most important to know is that if the chest x-ray shows findings highly suggestive of tuberculosis, we send the patient for nucleic acid amplification test, and basing upon that result, we stamp the case as a microbiologically confirmed tuberculosis or a clinically diagnosed tuberculosis, and additionally we got the information about rifampicin resistance also. Now coming to the chest imaging in tuberculosis. So what are the highly suggestive findings and what are the non-specific shadows? From the previous slide, think about the red box and the yellow box. So what are the findings that are highly suggestive of tuberculosis? That means what are the findings seen only and only in tuberculosis, which will help us in diagnosis of tuberculosis again. So there are mainly three things. One is miliary shadows, one is intrathoracic lymphadenopathy, and one is chronic fibrocavitary shadows. Presence of one of these three things, miliary shadows or intrathoracic lymphadenopathy or chronic fibrocavitary shadows, is highly suggestive of presence of tuberculosis in any patient. What are the non-specific shadows? That means this is the chest x-ray is not normal but not specific for tuberculosis also. That means may be present in other cases also. These are consolidations, inhomogeneous shadows and bronchopneumonia. These are often confused with tuberculosis, but these are not highly suggestive of tuberculosis. And as we discussed before, if we find these findings in a chest x-ray, what will you do next? What you do next? It may be also seen in other bacterial diseases. We have to start an appropriate antibiotic therapy, preferably amoxicillin or co-amoxiclav for 7 days and reassess. Linezolid, fluoroquinolones, aminoglycosides, etc. should be avoided as the first line therapy as they have anti-tubercular activity. This is the point I want to focus on. Many times you may be seeing a patient, suppose 9-month, 10-month, 12-month-old child has come to the hospital with complaint of hurried breathing or fast breathing complaint by the parents. You examine, you find tachypnea, you find fever, you find some degree of respiratory distress. What is the antibiotic given initially? Ceftriaxone and amikacin. Is that prescription correct? That is wrong. Why? Ceftriaxone is okay, but if you are giving amikacin, amikacin has antitubercular activity. Suppose that patient has tuberculosis. You have given amikacin. The patient will transiently improve. You will think, okay, my antibiotic has worked wonders. The parents will thank you. The parents will go home. 6 to 7 months, 1 year later, the patient will come as a case of drug-resistant tuberculosis, and that is a nightmare for the pediatricians. Why? If you see the drug-resistant tuberculosis treatment algorithm, you will faint. So that's why it is a nightmare for the pediatricians, and no one wants a child to have any drug resistant pathology. So always avoid aminoglycosides, linezolid, fluoroquinolones, or any antibiotic which has antitubercular activity initially as the monotherapy. Especially if there is non-specific shadows, that means the findings are not suggestive of tuberculosis. So what are the CT scan findings suggestive of tuberculosis? Necrotic mediastinal lymphadenopathy, central lobular nodules with tree in bud pattern, and cavities with surrounding consolidations. We'll discuss all this later on. So see this X-ray. What findings can you see in this X-ray? Can you see the diffuse micronodular shadows affecting both lungs like a snowstorm? These are called the miliary shadows. These are very highly specific for presence of pulmonary tuberculosis. Okay. Can you see this X-ray? What can you see here? Can you see these two lymph nodes? Hilar lymphadenopathy. There is dense, well circumscribed ellipsoid or rounded shadows in the hilar or mediastinal regions. This is intrathoracic lymphadenopathy. This is also a finding that is highly specific for presence of pulmonary tuberculosis. Can you see this X-ray? What can you see here? Can you see the cavity and lung fibrosis? So this is a fibrocavitary shadow. This is also a finding that is very highly suggestive of tuberculosis. What can you see here? This is a finding that is often confused with tuberculosis. See in this X-ray, suppose a patient comes to you with fever, cough, cold, hurried breathing with this X-ray. What will you think? Any person that initially sees this X-ray, he will think that okay, increased bilateral hilar opacities and some opacities present in the right apical region or right upper zone and right lower zone also. Increased bilateral hilar shadows, the person may tend towards thinking about tuberculosis, but this is not. What is this exactly? Can you see the multiple small nodular reticulonodular opacities which are patchy? This is a patch, this is a patch, this is a patch, this is a patch. These are patchy areas of lungs where there are patches of inflammation separated by a normal lung parenchyma. The areas that are seen as white are the areas of inflammation. The areas that are seen as black are the areas of normal lung parenchyma. This is bilateral, asymmetric, predominantly involving the lung bases. This is characteristically a finding of bronchopneumonia. You can see the peribronchial inflammation, you can see the patchy consolidation. This is a finding of bronchopneumonia. This comes under the non-specific shadows, not highly specific shadows for tuberculosis. So what is to be done in this case? You have to give an appropriate course of antibiotics, preferably with one which doesn't have antitubercular activity. Can you diagnose this X-ray? Few days back, this patient came to our hospital. So any patient who is coming to you with this X-ray, at first sight, within a second, if you don't spend 2 minutes to examine this X-ray, at first instant, what will you think? Oh, there is no bronchovascular markings here. There is means increased blackness, and so you will think that this may be a case of pneumothorax, and you will do what? You may do needle thoracostomy, or you may try thinking about inserting an intercostal drainage tube. But then you think, if this had been a case of pneumothorax, the trachea would have shifted to the other side, because pneumothorax is a pushing lesion, not a pulling lesion. Why is the trachea deviated to the right side then? Because this is a pulling lesion. So what can cause a pulling lesion? You can think this is a cavity actually. This is not a pneumothorax. This is a cavity, and cavity associated with fibrosis as seen by the rib crowding. So this fibrocavitary shadow is a pulling lesion, and it's causing the pulling of trachea to the ipsilateral side. So this is actually a case of chronic fibrocavitary shadow. This patient has a history of tuberculosis. So this is actually a case of chronic fibrocavitary TB. So can you see the shadow here? This is This is fibrocavitary shadow and the trachea is shifted to the same side. So this is a case of chronic fibrocavitary TB. So this is a important NEET PG MCQ. What is a bleb, what is a bulla, what is a cyst and what is a cavity? A bleb has wall thickness less than 1 millimeter and diameter less than 2 centimeter. A bulla has wall thickness less than 1 millimeter but a diameter of more than 2 centimeter. What is a cyst? A cyst has wall thickness slightly higher, that is 1 to 4 millimeter, and a cavity has wall thickness more than 4 millimeter, and if there is air fluid level present inside the cavity, it is called an abscess. It's an important NEET PG MCQ. So what is the chest imaging in a patient who has been previously treated for tuberculosis? What are the post-TB changes? Suppose a patient has been diagnosed to have tuberculosis and has been treated before. So what can be the post-TB changes that we see? So one is pleural thickening. Second is fibroatelectatic changes like we saw just now. And third is areas of bronchiectasis. The pleural thickening and the fibroatelectatic changes are usually asymptomatic. They are not usually associated with any symptoms. But if areas of bronchiectasis are there, there may be symptoms of suppurative lung disease. So what we need to do in those cases? That patient needs evaluation to differentiate and confirm disease recurrence. That means you have to think whether the child has again developed tuberculosis, and depending upon your investigations, you have to treat. So coming to the microbiological testing in tuberculosis, we already learned that to confirm microbiological tuberculosis, you have to send an appropriate sample for NAT, that is nucleic acid amplification test. So what can you send? You can send either gastric aspirate for swallowed sputum or induced sputum, or if the patient can expectorate, that will be very good. You can send expectorated sputum. So how to send gastric aspirate? You have to send the gastric aspirate after the patient has fasted for 4 to 6 hours, and you have to send the early morning sample preferably. And in case of induced sputum, children who are unable to produce sputum, they can be induced to produce some sputum by nebulization, and this doesn't require prolonged fasting, and adequate infection control practices are needed in this case because this is a aerosol generating procedure and may lead to spreading of infection. So this is the conical falcon tube that is used for sending the appropriate specimen for nucleic acid amplification test. Recently discharged material from deep inside the chest or inner airways is collected. The minimum amount of oral or nasopharyngeal material is 2 to 5 ml. Mucoid or mucopurulent character is appropriate. Collected in a sterile container after rinsing the oral cavity with clean water in this container. If delay in transport to lab is unavoidable, it can be refrigerated to avoid unwanted growth and must be tested no later than 7 days after collection. This has a high positive predictive value, no negative predictive value, and performed poorly on pleural, pericardial, synovial and ascitic fluid specimens. That means among all the specimens, pleural, pericardial, synovial and ascitic fluids have very low sensitivity for positivity in nucleic acid amplification test. There are mainly two types of nucleic acid amplification test available. One is expert reef, one is TrueNAT MTB+. The expert reef is a cartridge based nested NAT and it detects the resistance to rifampicin as we discussed in the presumptive pediatric TB algorithm. The TrueNAT MTB Plus is a chip based NAT and it detects the resistance to rifampicin using MTB Reef DX technology. So what is the role of bronchoscopy and bronchoalveolar lavage? We learned before, if the initial test or initial NAT in the appropriate specimen in a case of highly suggestive findings in the chest X-ray comes negative, we can think about sending bronchoalveolar lavage. So what are the indications of sending bronchoalveolar lavage? Because bronchoalveolar lavage is an invasive procedure. You have to do bronchoscopy and get the same sample from there. So it is an invasive procedure, it's a painful procedure, requires higher things, requires anesthesia. So we have to think properly if there is any proper indication or not before performing this. So if the patient is not producing sputum even after induction, if routine investigation for TB are inconclusive, like we discussed in that algorithm, if the patient is a suspected case of drug resistant tuberculosis and selected cases of persistent pneumonia, think about that algorithm. Non-specific shadows, we gave antibiotics, the patient did not improve, there was persistent shadow, persistent symptoms, then we sent the patient for bronchoalveolar lavage. So it should also be subjected to culture and drug sensitivity testing. That means if you are getting this high profile sample means we have to think about getting all the tests done in one go, so that the patient doesn't have to be undertaken for this painful procedure again and again. So this has to be taken for culture and drug sensitivity testing also. Now coming to line probe assay, this test can take up to 72 hours. This is only used in smear positive sputum specimens or culture isolates for genotype drug sensitivity testing. That means if we have sent a sputum sample for smear testing and that comes positive for acid fast bacilli, in that case we have to take that sample and examine for or test with line probe assay for genotype drug sensitivity testing. This is the only WHO and NTEP recommended test to detect additional drug resistance in case of multi-drug resistant TB and extensively drug resistant TB. There are mainly two types of line probe assays available. One is Hain test or MTB-DR plus, another is MTB-DR SL. The MTB-DR plus detects first, is called the first line LPA, line probe assay, and the MTB-DR SL is called the second line LPA. SL stands for second line. So obviously the first line LPA will detect resistance to isoniazid and rifampicin, and the second line LPA will detect the resistance to second fluoroquinolone and second line injectable drugs. So suppose we do expert RIF or TrueNAT testing in a case of presumptive pediatric tuberculosis, and as we discussed before, in addition to giving or informing about the presence or absence of tuberculosis also, it will also give us the information about the presence of rifampicin resistance. So if suppose the rifampicin resistance is not detected, we straight away start with the first line drugs, as this is a case of drug sensitive tuberculosis. But suppose if rifampicin resistance is detected, that means there is a high chance that this is a case of drug resistant tuberculosis. So what do we do next? We ask ourselves three questions. Is this a new case? Are there no risk factors for drug resistant tuberculosis? And is the Mycobacterium tuberculosis detected very low? If answer to all these questions is yes, we have to do retesting. We have to retest with expert RIF or TrueNAT. But if answer to all these questions is no, then we have to take the patient for first line probe assay and second line probe assay, because there is a high chance that this is a case of drug resistant tuberculosis. Now after taking the patient for first line probe assay and second line probe assay, what can happen? Suppose in this test rifampicin resistance is not detected, then what do we do? Initially rifampicin resistance was detected in TrueNAT, but line probe assay is telling that rifampicin resistance is not detected. That means our line probe assay and TrueNAT testing is not matching. So what we have to do? We have to repeat the NAT, and culture and drug sensitivity testing has to be done so that the actual image can be known. But suppose if rifampicin resistance is detected here, 2 times rifampicin resistance has been detected, so this is a confirmed case of drug resistant tuberculosis. So we have to take the patient as a case of drug resistant tuberculosis and treat him as a case of drug resistant tuberculosis as appropriately. Some other tests in tuberculosis, most famous test, tuberculin skin test. What is its importance? This test detects delayed hypersensitivity to tubercle bacilli. It is used as an adjunct to other tests, and it has the same connotation as history of contact, because all that tuberculin skin test tells us is that the tubercle bacilli has been present in the body of this person. It doesn't tell us anything about the presence or absence of an active infection. So this has the same connotation as history of contact. That means by telling that a person is TST positive is the same as telling that a person is having some positive contact history with tuberculosis. That is all. And the dose is 2 tuberculin unit of PPD RT23, but as all the commercial available preparations are 5 TU and this is not available, so actually this is impossible to perform as of right now. So this test, if performed, has to be treated very cautiously, and the results have to be treated very cautiously. As always, the more than 10 mm is considered as positive, but in HIV positive patients, more than 5 mm is also considered as positive, and all that positivity means is having a present or past infection, not a disease, and it cannot distinguish between infection and disease. What is IGRA? That is interferon gamma release assay. It is an in vitro measure of Mycobacterium tuberculosis hypersensitivity, so basically same as TST. It has the same information as TST. Two types of tests are available. One is quantiferin gold and what is TB spot. Repeat visit is not needed for reading, because in case of TST the patient has to be visited again after 72 hours. No cross reaction with BCG vaccination can be seen, which is seen in case of tuberculin skin test. It needs rapid transport to the laboratory and it's an expensive test. So this is one example. This is a normal appearance just after the TST injection. You can see the PUD orange appearance. This has to be injected intradermally. So this is the normal appearance after just injecting tuberculin skin reagent. If you inject too deeply, this PUD orange appearance will not be there, and after 72 hours when you examine, there will be only increased redness, but there will be no induration. So that will confuse you more. So this appearance if you have got after injecting means your procedure has been appropriate. And this is an example of induration seen after 72 hours. Induration is a palpatory finding, so it cannot be actually seen, but if you look deeply, you may be able to appreciate the finding here. And this is one example of some findings we get sometimes in tuberculin skin test. Sometimes blisters are seen. So this is an example of blister seen after 72 hours after giving tuberculin skin reagent. Two other important tests, one is erythrocyte sedimentation rate and one is CTB. What does ESR do? Previously we used to rely a lot on ESR for making a diagnosis of TB, but as of now this is a non-specific test, we all know, and it has no value in either ruling in or ruling out diagnosis of TB. That means suppose if a person's ESR is very high, we cannot tell that the patient is positive for tuberculosis. Suppose if a patient's ESR is low or normal, we cannot tell that the patient is not having tuberculosis. What is CTB? This is a next generation skin test for detection of tubercular infection. It has a cutoff of 5 mm. It is based on ESAT6 and CFP10 antigens. It is unaffected by BCG vaccination like IGRA, and it is currently unavailable commercially and is manufactured in Statens Serum Institute, Copenhagen, Denmark. So what are the key learning points from today's session? Presumptive pediatric TB, your diagnosis mainly relies upon chest X-ray. Microbiological diagnosis mainly relies upon nucleic acid amplification test or NAT. First line probe assay and second line probe assay has to be done from culture samples for smear positive cases. TST or tuberculin skin test has no role in ruling in or ruling out tubercular diagnosis. All it tells us is that the patient has tubercle bacilli in the body either now or previously. It has the same connotation as having a positive contact history with tuberculosis, and an appropriate sample collected by appropriate methods sent in an appropriate container to the appropriate laboratory will help us in diagnosing pediatric tuberculosis reliably. If you like this video, press like, share and subscribe with your friends. Thank you.